I am Dr. Parashar. With me is Ashish, and we are discussing some very basic aspects of Doppler, and we will be discussing it on the GE machine E95. Now, every echo has got three basic components. Number one, a clinical evaluation. Number two, a anatomical evaluation, and number three, a hemodynamics. All the three are important. For example, an anatomical examination or a 2D examination always gives rise to a semi-quantitative idea of a severity. For example, suppose you take a case of aortic stenosis. The more calcified the valve it is, the more the restricted opening, the more the LVH, it indicates that possibly we are dealing with a severe stenosis. However, a full evaluation of the severity is by hemodynamics, and the hemodynamics depends upon a Doppler examination. The Doppler derives its name from an Austrian physician, Christian Johann Doppler, who first described the Doppler effect. Now, the role of Doppler is in assessing a hemodynamics. How? A Doppler records velocities, and the velocities are converted into gradients by the formula 4 into velocity square. Now, if your velocities are incorrect, then your gradient will also be incorrect, because the basic thing is always of a velocity. That is why, remember, in a Doppler, we have all examinations, whether they are conventional views or unconventional views. Our aim in a Doppler study is always to get the maximum velocity. Now, the Doppler is based on basically three factors. One should be a sound source, and the sound source in a Doppler is a transducer, that is the sound source. The receiver are the millions of the RBCs which are circulating in the body. Now, whichever view you take in a 2D echo, the transducer is always pointing from above downwards. So, there are two basic principles of Doppler. Number one, any flow which is directed towards the transducer is shown as a positive wave, or above the shift known as a positive Doppler shift, and any flow which is against the transducer angulation gives a negative Doppler shift, or below the baseline. Second very important principle is that we have to be as parallel to the flow as possible. That is the basic rule of a Doppler. That is just opposite a 2D echo. In a 2D echo, you get the best results when you are perpendicular to the structure, while in a Doppler, you get the best results when you are parallel to the flow. So, that is why we always take both conventional and unconventional views to see a Doppler velocities of flow. Third thing, that if you are not completely parallel to the flow, your velocities will be reduced. For example, if you are maximum allowed about 15 to 20 degree off angle, which gives a minimum error in calculation, otherwise it should be as parallel as possible. Now, basically the modalities of the Doppler are a pulse Doppler, a continuous wave Doppler, and a color Doppler. So, a pulse Doppler contains just one crystal, and it goes on sending and receiving impulses. And the idea of a pulse Doppler is, the advantage is that you can record at any particular site you want to study, that is known as a sample volume. For example, Ashish will now demonstrate. Now, this is a 4-chamber view. Just we will take a apical 4-chamber view, which will show the 4 chambers. This is the left ventricle, left atrium, right ventricle, right atrium, and the mitral wall is in between. Now, whenever we want to record a velocity, we take the help of a color flow mapping. So, he will put a color flow mapping, because the color flow mapping tells you the direction of the flow exact. Now, he will put a pulse Doppler. Pulse is like a sample volume. If you can see here, can you show the pulse first? remove the color. Can you see a cut here? That is the pulse sample volume. So wherever you put a sample volume, you record the velocity only from that particular area. So we normally record from the tip of the leaflets. So now he'll put a pulse Doppler on the tip of the leaflet. Now can you freeze it? Now because the blood is going towards the transducer, it is shown as above the baseline, which is known as a positive Doppler shift. Similarly, he will take an aortic wall and we expect a shift below the baseline because the blood is going away from the transducer. Hence, if we put a Doppler here, you see the shift will be basically below the baseline, that is a negative Doppler shift. The advantage of it is that if you are expecting a positive Doppler shift and you get a negative also, that means some blood is going away from the transducer, that means there could be a regurgitation. So once you know the normal flow pattern, that where it should be a positive Doppler shift, where it should be a negative Doppler shift, then you can see what is normal or an abnormal. So the advantage of a pulse Doppler is that it records a velocity from a particular site. Whenever you record always from the tip of the leaflets. And the basic take home message for recording by a pulse Doppler is that in which view that valve is best seen, and am I parallel to the flow? For example, here now he is parallel to the flow. Now let him take a parasternal long axis view. Now here you see, this is the mitral wall, but you are not parallel, you are perpendicular to the flow. So the basic dictum of a valvular pulse Doppler is that am I in which walls, in which scan planes am I seeing the wall, and am I parallel to the flow? For example, mitral wall, you can see best from the apical 4-chamber view, apical 3-chamber view, or apical 2-chamber view. Similarly, tricuspid wall, you can see from RV inflow view, you can see from a short axis view, apical view, and a subcostal view. So these are some of the basic things. However, the disadvantage of a pulse Doppler is that it records only a low velocity flow. That is known as a Nyquist limit, that is the maximum measurable flow which can be detected by a pulse Doppler is known as a Nyquist limit. Beyond that, there is something known as an aliasing. So aliasing means that we are beyond a particular direction. So for example, if we take an apical view, we will artificially demonstrate an aliasing by reducing the velocity scale or by changing the baseline. So the signal above the baseline, now you see, you are seeing the signal both above and below the baseline. So that is known as aliasing, which is a feature of only pulse Doppler. So that aliasing can be now removed by increasing the velocity scale. So that is one thing which we always see, and there are ways to remove this aliasing. So the pulse Doppler is usually used for recording of no flow velocities across normal valves, normal blood vessels, finding out stroke volume, cardiac output, or for a diastolic dysfunction assessment. There we use a pulse Doppler. As compared to a pulse Doppler, there is something known as a continuous wave Doppler. A continuous wave Doppler has got two crystals, one is a receiver, one is a transmitter. Now the things of a continuous wave Doppler is it records flow across the whole of the Doppler line. There is no sample volume. So the advantage of this CW Doppler is that it records very high velocity flows. So that means all disease flows like stenotic lesions, regurgitant lesions, valve areas, all of them are determined by a continuous wave Doppler because there is no aliasing in it. Now we will demonstrate the CW Doppler. We can take the aortic valve. There is a knob to, first of all we must set ourselves parallel to the flow, and that is done by a color flow mapping, so that we know which direction the flow is going there, and then we can put a CW Doppler. So now it is recording the flow across the whole Doppler line, but depending upon which is at what timing we see, systole or diastole, what direction of the flow we are seeing, we can presume that it is from that particular area. For example, he has put a CW Doppler on the aortic valve. Now we know that aortic valve has a negative Doppler shift because it is against this. Number two, aortic valve has got a higher velocity as compared to any other structure in the left ventricle. Hence we know, although it records as a continuously from the whole Doppler line, but it gives us an indication from where we are recording it. So to summarize with these Dopplers, a pulse Doppler records low velocity flow, a CW Doppler records high velocity flow, a pulse Doppler can record from a particular site known as sample volume. There is no sample volume in relation to a CW Doppler. There is aliasing in pulse Doppler when it goes beyond a certain Nyquist limit. There is no aliasing in CW Doppler because it records a very high velocity flow. So these are the basic principles and these are the basic things. So remember that whenever you want to study a disease flow, you always take a CW Doppler. For the beginners, the best thing is start with a pulse Doppler, and if you get a aliasing, there are ways to reduce the aliasing by increasing the velocity scale or by coming to CW Doppler. So we'll again show you an aliasing. If you can see, there are three ways to remove aliasing. One is by increasing the velocity scale. He has increased the velocity scale and the aliasing disappears, or you can take the baseline in the opposite direction. When you take a baseline above, the velocity scale comes down, increases also. So that in a Doppler, we have to see the velocity is always seen above the baseline, the timing is always seen on the horizontal axis. A timing is done in horizontal axis and a velocity is seen at the above or below the baseline. So these help us in the quantitation of every lesion, and the advantage of Doppler is that in a large number of conditions, now we don't do any invasive studies, because a good echo examination with a Doppler gives us a complete anatomical and the hemodynamic diagnosis. And for example, various valvular lesions, many congenital lesions, we don't have to do a cardiac catheterization because all information is given by a Doppler. The third thing is basically a color flow mapping. As you know, our basic aim is to always be as parallel to the flow as possible. Now sometimes the jets can be very eccentric. If the jets are very eccentric, you don't know where you are placing your Doppler, CW Doppler or pulse Doppler, and you may struggle it and never see where you are putting your Doppler to get the maximum velocity. So the color flow mapping is a new technology based on the principle of a pulse Doppler, where you can actually see the blood flow. When you can see the blood flow, you can automatically put your Doppler parallel to the flow. By a universal convention, the flow toward the transducer is shown as a red color, as you see here. You see the flow going from the mitral valve toward the transducer, which is on the top, is shown as a red color, and the flow which is going away from the transducer is known as the blue color. So this is universal convention. Now if you see only red and blue color, how will you know where the disease? The beauty of this technology is that within few seconds it tells you where is the disease process. For example, let us take example of a patient with a systolic murmur. It can be because of pulmonary stenosis, it can be because of a VSD, it can be because of MR. So if you have put a color flow mapping in the pulmonary area and there is no turbulence, turbulence is created by adding a certain color which the machine automatically acts, and it is known as a mosaic pattern or a multicolored pattern, as you see. So if suppose pulmonary valve is normal, then you put it on the IVS side and see if the turbulence is there. So turbulence is a mixture of colors besides red and blue, and it was known as a mosaic pattern. So wherever you see a turbulence, it indicates that it is a disease process. So this is how you see and because it is based on a pulse Doppler, so you can again see that there can be you can see some sort of an aliasing. That means the outer color is blue, but the inner color is red because it is again based on the principle of a pulse Doppler. So that to summarize, a Doppler gives you a complete hemodynamic information and complete quantitative information. Best you have to be as parallel to the flow as possible. So have as many pure conventional and unconventional views to get the maximum velocity, that is your main aim. Use all abnormal or normal views to again get a maximum velocity. For a normal blood flow, you use a pulse Doppler. To localize the flow at a particular region, you use a pulse Doppler. For all high velocity flows, you use a CW Doppler and then record, because the velocities which is usually in meters per second. And once you have recorded that, by a Bernoulli equation 4 into velocity square, you can get all calculations in this thing. I think this is the basic which I wanted to tell you, so that because you can practice and you see whatever you want to see another further.